today's webinar, a pragmatic approach to developing a pulmonary embolism program. I would now like to introduce Eileen Sue, EKOS Marketing Manager, who will be introducing today's speaker.
Thank you, Kat, and thank you everyone for joining us. I have the great privilege of introducing Dr. Chad Laurich of Sanford Vascular Associates. Even though most of us have only heard of PE response teams, or PERTs, within the past couple of years, Dr. Laurich was instrumental in developing the equivalent of a PE response team at Sanford Health in late 2011. He's also seen it scale successfully as Sanford has grown, so he's uniquely qualified to give this talk. He gives a pragmatic approach to PE program development, so, as you'll hear today, you'll pick up tips and guidelines that will work for you, no matter what size your institution. He is currently the Medical Director of Sanford Vascular Ultrasound Lab and a Clinical Assistant Professor at the University of South Dakota. With that, I'd like to turn this over to Dr. Laurich.
Well, thank you, Eileen. It's going to be an exciting talk, I think. This has been a big part of my life and our practice here at Sanford. It's been really gratifying as we've developed this and continue to develop it. So let's get going. So a multidisciplinary PE response program. So disclosures, consultant for Medtronic Bard CSI in addition to EKOS. And let's start out with a couple definitions here and rationale. So multidisciplinary team to coordinate and expedite appropriate treatment of pulmonary embolus. So coordination and expedition of care. The rationale is this is a complex medical problem with multiple clinicians involved in the diagnosis and multiple treatment options spread across multiple specialties. And then this team is modeled after other acute healthcare teams, such as the heart team or the rapid response teams. So let's start off with the poll here. Where is your facility in the process of developing a PE response program? Not yet started, have some buy-in, members are identified and starting to meet, you have process and protocol and starting to implement, or your team is fully functioning. So we'll give a minute here for people to respond. All right, responses are coming in. So it looks like the majority of people on the call are just not quite yet started, or they have some buy-in and considering options. And that's excellent. That's a great spot to be. We're going to talk a lot about how to get a team up and a program up basically from scratch and get it rolling. We'll talk about how we did that and kind of things that I've seen around the country as well, ways to do it and pitfalls. So let's get on with things here. Let's talk about PE a little bit, some obligatory background slides. You know, the annual incidence of PE is quite high, over 600,000 cases annually, and it is commonly originates in the lower extremities as a DVT in most patients, and most of those patients do have evidence of a DVT. And this occurs very frequently in people with proximal DVT. So risk stratification for PE, this is a fantastic slide. Talks about the different types of PE. We're thinking more of this as a massive PE. Those are the ones that obviously come in and with hemodynamic instability. Fortunately, those are the minority of patients. The minor ones are the walkie-talkies, as we say. They're the people that come in and they're normotensive, maybe even on room air, and doing well. The submassive is I think the underserved population that we're talking about mostly here. These are the people that come in and they look decent. Maybe they're hemodynamically stable on the surface, but if you look under the surface a little bit, they're going to have right ventricular dysfunction. And that's the real key. Is that right ventricle being affected or not? There's a couple of ways to look at that. One is by CT, with the picture on the right, just to look at the right ventricular size to the left ventricular volume. And that ratio, the right ventricular should be less, of course, than the left. If that volume reaches 0.9 or 1, the ratio between the right and the left, where the right's getting bigger, that's significant. Other ways to look at this is look at the BNP, look at troponin for lab values, some EKG changes, or, of course, look at echo to see these findings as well. So looking at the different rates of this, you know, the massive ones, obviously, like we said, are the minority, fortunately, 5%. The minor are the majority, over half, 55%, but the submassive, it looks like it's up to 40% of the population. And these are the people that can have significant mortality over the following 90 days. There's been studies anywhere from 2 to 20% in mortality rates over the next 90 days with the submassive group. So why is right ventricular strain or dysfunction important? And there's been a number of series that have looked at different angles of this, and we'll go through a few of these. So the presence of right ventricular hypokinesis was associated with a definite increase in mortality at 3 months. This is a prospective study of over 2,400 patients at multiple hospitals. So looking at adverse outcomes with mortality based on the ratio of RV/LV over 0.9 and based on the echo. And this was a predictive of independent hospital mortality. And this is a registry of over 1,400 patients. And if the ratio was less than 0.9, it was 1.9%. If it was over 0.9, it was 6.6%. So looking at adverse outcomes again here with RV/LV ratio over 0.9 at 30 days, and this is all adverse events included in this, and it was 80% versus 50%. And then looking at unresolved right ventricular dysfunction, these people had an 8 times recurrence of incidence of recurrent thromboembolism. This is looking at the 301 patients. So the key factor here contributing to hemodynamic collapse in the QPE, this is a bit of a schematic here, but it's kind of the mechanism of you get right ventricular dysfunction that leads to increased pressures, increased demand in the muscle wall, decreased contractility, and then you kind of start to go down with decreased preload and delivery, and you kind of start to spiral. And in fact, not to distract with too many stories, but we did have a patient that recently came in, or that I talked to, recently came into one of my colleagues' hospitals, and they saw this happen right in front of their eyes, and I think they're fully committed now to treating these patients. This is just a story from last week. He called me and said, hey, you'll never guess what happened. But thinking about therapies now, standard PE therapy obviously is anticoagulation. And this has been the standard of care for quite some time, starting on low molecular weight heparin or unfractionated heparin, and then transitioning to an oral agent. You know, in the past, it's been a warfarin. Although the 10A inhibitors are coming on strong now. And this has been, like I said, the standard of care. And this obviously stabilizes the situation. It doesn't break down any clot. You're relying on that endogenous fibrinolysis to break down the clot and resolve the clot. And that's a process that happens over several weeks to months. So the rationale for lysing the clot in the QPE is obviously to reduce the thrombus burden. You want to reverse that RV afterload and to prevent hemodynamic collapse. That's the big thing. The other thing is improving reperfusion, gas exchange, and restore normal systemic arterial perfusion pressure. The other thing that's pretty hard to prove, but you would hope that with time we could prove this, but this is pretty difficult, but is a decrease in chronic pulmonary hypertension. That's something that obviously develops over time and usually fairly far out from the event. But that is another big aspect. It's fairly more for people in that particular setup. So here's a meta-analysis looking at thrombolysis, suggesting that there's a reduced risk. And this was a meta-analysis of multiple clinical trials, 11 trials with 748 patients. And this did include some massive patients as well. And it looked like recurrent PE death did decrease with lytic patients versus heparin alone. This is a randomized trial looking at the benefit of IV thrombolysis in the intermediate risk group PE, the PITO trial. And this was looking at normotensive patients with acute intermediate risk PE. So again, what we would now call probably more that submassive type patient. And this showed that all-cause mortality at 7 days is not different, but you did prevent hemodynamic collapse with a much improved rate, with a decreased need for CPR, decreased hypotension, and decreased pressor need. But this is at the cost of major bleeds, which is why the death rate overall was probably kind of similar. So the major extracranial bleed and intracranial bleeding as well was higher in the systemic lytic group. And overall, the adverse event rate at 30 days was no different. So the adoption of IV thrombolysis is hampered by elevated risk of severe bleeds. And this has been shown in randomized trials with a significant increased risk of bleeding. So that's where other methods come in. And the EKOS system is shown here. This has the drive unit, which powers the ultrasound. You have a catheter, an infusion catheter with an ultrasound core, which goes inside the catheter. So you deliver the catheter over the wire just like any other catheter, and then remove the wire and put the ultrasound core in, and then hook it up to the power unit. And you can infuse, obviously, the medicine is a drug port and a coolant port as well. So those are the sizes. It goes through a 6-French sheath. The sizes go from 6 up to 50 centimeter treatment zones, and they have up to 135 centimeter working lengths. So FDA clearance, this is approved for infusion of physician-specified fluids, i.e. TPA, whatever the physician identifies. And this is indicated and is the only device out there currently indicated for placement in the pulmonary arteries for treatment of PE. Mechanism of how this works is the ultrasound will help fragment and separate the fibrin connections to allow better penetration of medicine, and then the actual ultrasound waves will power the medicine through the fluid medium into the fluid medium of the blood into the clot. So a few studies that have looked at EKOS, the Ultima study compared EKOS to heparin in intermediate risk PE. And the primary objective was to find whether a low-dose catheter-directed lytic therapy with the ultrasound-assisted catheter would be superior to heparin alone in reversal of that right ventricular strain in the submassive group. So this randomized 30 patients to 29 patients, and the criteria was the RV-LV ratio over 1. The infusion protocol there is in the bottom left, milligram an hour over 15 hours. So the results, EKOS, looking at the ratio, improved significantly over the treatment period of time, and this is baseline to 24 hours. And then also out at 90 days, you had continued improvement and significance over heparin. So you got improvement at 24 hours initially, and you got improvement out to 90 days as well. So this is a great slide. Initially, it's very busy. Looks like it's like belongs on a Christmas tree. But if you look at it closer, the EKOS group is on the left, the heparin group's on the right. Green is good. So green is normal function. So even out at 90 days with the EKOS group, you get close to 80% normal function, and the rest are mild dysfunction. With the heparin alone group, you get less than 40% to around 40% normal with mild, but you also have significant severe and moderate dysfunction still at 90 days in the heparin alone group. So there's no statistical difference in safety as well with EKOS compared to heparin. Bleed deaths, recurrent events, bleeding rates, major and minor bleeding rates were no different. Examined EKOS as well. This looked at EKOS in massive and submassive patients, 150 patients overall, across 22 centers. Measured the reduction in RV-LV ratio as well as safety, measured by major bleeding rates. So the protocol is at the bottom, milligram an hour with one device, or milligram an hour per device over 12 hours, and then follow up at 48 hours with CT measurement and echo measurement of PA pressures. The total enrollment again is 150 patients. Massive were 31 out of those patients. And then you see the other rates of previous DVT, PE, and most were bilateral as well, 20 unilateral, 130 bilateral. The average TPA dose was 23.7 milligrams. And that's important. I think, when I review the literature of all types of lytic, I think there's more of an inflection point at around 25 to 30 milligrams total treatment dosage of TPA where your bleeding rates will go up. So that's important, I think, to stay under that level. Now, this looked at the reduced RV-LV ratio in the modified Miller score at 48 hours post-EKOS. So you had a significant reduction in both of those parameters. And this looks at the pulmonary artery pressure. Again, you get significant reduction in that pulmonary artery pressure. which that goes along as well. You think if you're going to decrease the pressure, do you relieve the obstruction, decrease the pressure, decrease the strain on the ventricle. All those things are connected physiologically. So there's no cases of intracranial hemorrhage reported on the study. And in summary, right ventricular dysfunction in PE patients does predict poor outcomes: mortality, adverse events, recurrent events. Anticoagulation therapy does not actively resolve the existing thrombus. And IV thrombolysis is not used broadly, as it does show improvement in hemodynamics, but at the risk of, at the cost of increased bleeding, and including intracranial bleeding. EKOS has been shown to, in multiple studies, the Ultima and Seattle 2 trial, to be effective and be safe.